Hi everyone, we would like to thank the organizers for inviting us today to present our data, but first, here are our conflicts of interest, and I would also like to inform you that results and some conclusions may differ from the submitted abstract, as an amendment extending the data collection period was approved since the abstract was submitted. So, Dolutegravir was chosen as the main focus of this project, as Dolutegravir-based antiretroviral regimens are recommended as first-line and salvage therapy for HIV in all populations due to their efficacy and safety, including for the pediatric population. In pediatrics, it is available in 2 formulations, which are dispersible and film-coated tablets, and doses are recommended based on weight bands. There are, however, some challenges in these populations, which include adherence issues, high interpatient PK variability, and limited co-formulations and data. Regarding these challenges, therapeutic drug monitoring, TDM, could help optimize Dolutegravir exposure in pediatrics. TDM is defined as adjusting patients' doses to optimize efficacy and limit toxicity based on plasma concentration measurements and clinical and virologic data. However, TDM utility remains understudied, especially in pediatrics, which brings us to the objective of this project, which was to describe the use and usefulness of Dolutegravir TDM in pediatrics. So today I'm presenting a sub-analysis of an active TDM integrase inhibitor study, which is a retrospective review of integrase inhibitor TDMs of the Quebec Antiretroviral Regimen Program. The Quebec Antiretroviral TDM Program from January 1st, 2011 to March 31st, 2025. And our sub-analysis for today is for Dolutegravir TDMs in pediatrics. Patients living with HIV under the age of 18 years old were included if they had at least one Dolutegravir TDM, but were excluded if all their times post dose were unknown or in the first half of the dosing interval. From the database, we collected data regarding patient demographics, TDM indications, viral loads, concentrations, TDM recommendations, and others. For trough concentrations, C-trough, they were estimated by extrapolation using age and weight adjusted mean population half-lives. And C-trough efficacy and toxicity thresholds were defined as greater than or equal to 0.32 mg per liter and 1.47 mg per liter, respectively. But however, please note that the toxicity threshold comes from a study conducted in adults as toxicity data in pediatrics are limited. As for viral suppression, it was defined as having a viral load of less than 50 copies per milliliter. Descriptive statistics were calculated and inferential tests were performed to compare the C-trough therapeutic status evolution over time and to study the association between C-trough and viral suppression. Now, for the result, the population was composed of 65 patients. At first TDM, the median age was 11 years old, 54% of patients were females, and 72% of them already had viral suppression. For all samples, the median C-trough was 1.85 mg per liter, and regarding C-trough therapeutic status, only 6% of C-trough were subtherapeutic, 22% were within the defined therapeutic window, and more than half were supratherapeutic at 54%. When stratified by weight band dose recommendations, we can see that the proportions of supratherapeutic C-trough were 50% or greater for most groups. In terms of variability, C-trough were highly variable between patients with an overall interpatient coefficient of variation of 51%, and when samples were divided into 2 age groups, we can see that the variability was more prominent in patients of less than 12 years old with a coefficient of variation of 69% compared to 34% in the older groups. As for the intra-patient variability, the median overall coefficient of variation was 34%, and it was similar in both age groups. As for TDM indications, pediatric was specified as an indication on 98% of TDM requisition, and this was the only indication for 89% of TDMs. And regarding pharmacist TDM recommendations, a dose decrease was recommended in 41% of TDMs, and an intake without food was recommended in 11% of TDMs. In both these cases, these were conditional to the patient having burdensome CNS toxicity, but following these recommendations, only 2 dose decreases were applied, and both were for the same patient. Regardless of TDM recommendations, some patients had dose modifications following a supratherapeutic C trough. The first patient had 1 dosing interval increase with 2 dose decreases, after which they reached a therapeutic level. And this patient had learning difficulties pre and post intervention. For patient 2 and 3, both had 1 dose decrease and both reached a therapeutic level after, and no CNS effects were reported for these patients. As for the last patient, they had 1 dosing interval increase, but they did not, they still had a supratherapeutic level after this modification, and this dosing interval increase was probably due to the fact that they stopped taking rifampicin. Now, here figure 3 shows the evolution of TDM results over time for the first 8 consecutive patients' TDM. Graph A shows that between TDM 1 and 8, the proportion of C trough above or equal to the efficacy threshold only increased by 1%. And for graph B, we can see that from TDM 1 to 8, the proportion of viral suppression increased by 6% between TDM 1 and 8. So overall, we can see that only small improvements were seen over time and were not statistically significant. Here, figure 4 shows the proportion of C trough below or above or equal to the efficacy threshold stratified by virologic response, that is either virologic failure, low viremia, or viral suppression. And we can see that for all groups, the proportion of subtherapeutic C trough were low, but was approximately twice as high for the virologic failure group compared to the 2 other groups. At last, a logistic regression was describing the relationship between viral suppression and C trough was generated, and C trough was not found to have a significant effect on achieving viral suppression. However, our logistic curve shows a lot of similarities with the one from the FDA, which was generated in treatment experience integrase inhibitor naive patients, which is representative of our population. As for study limitations, our limited sample size of subtherapeutic C trough and non-viral suppression could explain the non-significant association between viral suppression and C trough. And since this was a retrospective study, tolerability data were only available for patients followed at our hospital, which resulted into the inability to verify if pharmacist recommendations should have been followed. Regarding Dolutegravir toxicity, the C trough toxicity threshold we chose is from a study conducted in adults where 40% of patients with C troughs above or equal to 1.47 milligram per liter reported CNS toxicity within 6 months after Dolutegravir initiation. As for pediatric patients, it is known that there is CNS toxicity with Dolutegravir, as for example, the Odyssey trial reported suicidal behavior, depression, and other CNS effects, with a median time from inclusion to event of 72 weeks, that was the median. And to our knowledge, the C-trough toxicity threshold for pediatric has not been established yet and may perhaps be different than in adults, which is why we believe that future research should focus on defining the clinical significance of high dolutegravir concentration in pediatrics. And in conclusion, a large interpatient variability of the dolutegravir C-trough and a high proportion of supratherapeutic levels were seen in pediatric patients. A few dose decreases were done, which suggests that in cases of supratherapeutic levels, which suggests that the adult CNS toxicity threshold may not be clinically relevant in pediatrics, but it is, however, possible that some CNS effects were missed in our pediatric patients due to the difficulty to identify them in this population. As for TDM usefulness, only small improvements were observed in C-trough and viral suppression over time, which could indicate that routine TDM for the indication pediatrics may not be justified. And finally, current DTG dolutegravir weight band dosing recommendations could be optimized to limit unnecessarily high concentrations. Thank you.